Welcome, and thank you for joining us for today's National Alzheimer's and Dementia Resource Center webinar series, sponsored by the Administration for Community Living and hosted by the American Society on Aging. We'll be getting started in just a moment, but before we do, I want to cover a few housekeeping issues. The slides for today's presentation are available under the tab on your screen labeled Resources. And under the tab labeled CE Application Here, you'll find information on how to obtain CE credit for this event. You'll have 60 days, and that is 60 days, to complete a continuing education application, and it may take up to 30 days from the date of your application in order for us to process and issue your CE credit. If you are not logged in directly to this webinar, that is, if you are watching as a part of a group and did not log in using an individual confirmation URL, you will not be eligible for continuing education credit because we have no way to track your online attendance. If you'd like to receive continuing education credit, please be sure to log in using a confirmation URL you received after individually registering. If you have questions during the presentation, you can send those anytime using the questions box, and we will save those for the last 10 to 15 minutes of today's program. And now I'd like to welcome today's moderator, Sari Schumann, Senior Research Public Health Analyst and Co-Director for Aging, Disability, and Long-Term Care Program with the National Alzheimer's and Dementia Resource Center.
Thank you, Patrice, and thank you everyone for joining us today for the National Alzheimer's and Dementia Resource Center webinar, Community-Based Dementia Programs, Learning from Challenges and Sustaining Successes. The National Alzheimer's and Dementia Resource Center webinar series is supported by the Administration for Community Living. Before we start, Erin Long of the Administration for Community Living will provide a brief welcome. Erin?
Good afternoon, everyone. Thank you so much for taking the time out of your busy days to join us to learn about all of the work that's been taking place, or much of the work that's been taking place through our ACL grant programs in states and communities. I want to thank Heather Meny, Phyllis Rote, and Christy Nishida for taking the time to put together these presentations and share information on the good work that they've done over the years. And with that, I'll send it back to you, Sari.
Thanks so much. So as you heard, today we have with us Heather Meny, who is a Senior Health Policy Researcher at RTI in the Aging, Disability, and Long-Term Care Program. Dr. Meny is a skilled health policy researcher, project manager, and collaborator with federal and nonprofit experience and expertise in aging and disability programs and services. Her research career has focused on older people, people with disabilities, and long-term services and supports, with a specific emphasis on people living with dementia, family caregivers, and formal caregivers. We also have with us today Phyllis Rote, who is a regional coordinator for the Illinois Department on Aging, Office of Older American Services. Phyllis has been with the Illinois Department on Aging for 6 years and holds a bachelor's degree in education from Western Illinois University and a master's degree in gerontology from the University of Illinois at Springfield. In addition to working with Illinois' area agencies on aging, she is the state lead for the Illinois Department on Aging statewide initiatives Combating Social Isolation in Seniors and the Dementia Friendly America Initiative. Finally, we have Christy Nishida, who is a gerontologist and applied community-based researcher at the University of Hawaii Center on Aging. Dr. Nishida's work focuses on addressing the rapid aging of Hawaii's population and critical gaps in the system of care that supports older adults. As the primary investigator for Hawaii's Alzheimer's disease initiative, she has worked to develop more coordinated systems of care and services for people living with dementia and their caregivers. At this time, I will turn the floor over to our presenters, and we'll begin with Dr. Heather Meny.
Thanks, Sari. It's a pleasure to join you guys today. I'm just going to give a brief overview of some of the good work that's been going on across a number of ACL grants in recent years. And what we're going to talk about first is just a little bit of background. The Alzheimer's program began with AOA in like 1992 as the ADDGS, which evolved to the ADSSP program. Today, we're really going to focus on the Alzheimer's Disease Initiative Specialized Supportive Services Program that began in 2014. Really, the focus of that program, or what introduced to that program, was the opportunity for states and communities to kind of fill gaps to serve and support people with dementia and family members. This included providing supportive services to people living alone with dementia in the community, providing effective care and supportive services to persons living with moderate to severe impairment from dementia and their caregivers, improving the quality and effectiveness of programs and services dedicated to individuals aging with intellectual and developmental disabilities with dementia or those at high risk of developing dementia. And then delivery of behavioral symptom management training and expert consultations for family caregivers. Grantees, the states and communities that participated in ADI-SSS were encouraged and required to include evidence-based or evidence-informed interventions to provide services to people living with dementia and their caregivers. So just to give you an overview of what we did, there were 43 ADI-SSS grants awarded between 2014 and 2017. As of March this year, 29 had completed their grant work and submitted final reports, and we did a review of all of those reports, the really great information on the types of activities, the challenges, their methods of sustainability, and then we summarized those different elements. I'm going to walk you now through a few of the highlights that we found. So you can see on this slide, this shows that 25 grants focused on improving outcomes for people living alone with dementia. And most of those activities, 34, really were meant to directly serve people living alone with dementia. The type of activities here included case management or care navigation, implementing referral systems to make it easier for people to access services or supports, creating adult day programs, and even developing assessments to monitor progression of symptoms for people living alone. Grantees also noted that activities for educating people living alone with dementia included topics like basics of dementia, advanced care planning, and the availability of supports. Excuse me. When we look at activities related to people living with moderate to severe dementia, 18 different grantees reported activities in this gap area. The most commonly reported activities were aimed at directly serving caregivers and people with dementia. The activities here included groups or networks to provide support to caregivers, individual or caregiver needs assessments or consultation services, legal or financial planning workshops and access to those professionals, respite care, and evidence-based programs such as RCI's REACH. Programs specifically targeting or supporting people living with dementia could have been exercise programs, music programs like music and memory, or arts programs such as opening minds through art. Here we see the types of activities that filled the gap area related to intellectual and developmental disabilities and dementia. Here, training for professionals was the most common activity reported by grantees. And common themes for professional training included recognizing the signs and symptoms of dementia in people aging with IDD, diagnosing dementia for people with IDD, and dealing with dementia-related behavioral symptoms. Training for the grantee staff and their partners, also frequently noted by grantees, and the topics there were very similar to those offered to other professionals. '24 grants included activities related to improving the quality and effectiveness of programs and services dedicated to people. 25 of the grantees implemented 57 different behavior symptom management activities. Many of these used and fulfilled ACL's evidence-based or evidence-informed dementia interventions requirement here. Some of those programs included RCI REACH, tribal music and memory, and BRI care consultation. Here's a graphic that shows the number and name of the different evidence-based or evidence-informed interventions implemented by grantees. 17 different interventions were implemented, and some grantees exceeded ACL's requirement by implementing more than one evidence-based or evidence-informed intervention. The Savvy Caregiver program was implemented most often. 10 interventions noted here on the right were implemented by only one grant project. Grantees did include information about the different challenges they faced in their grants. Common challenges, and we hear this quite often, is around data collection and evaluation, how to obtain the data from caregivers or people with dementia. Sometimes issues with project staffing, needing to hire additional staff or addressing staff turnover, making sure that partner support is sufficient and supporting them to meet their grant obligations, outreach and recruiting participants to the programs. For some of these grantees, they were still implementing when COVID hit. And so a few of them, I think it was 4 or 5, were able to share some of their challenges related to this around delivery of programs and trainings. Many had to pivot to online trainings. Again, meeting the needs of people living with dementia, and then various staffing issues. And then grantees also did share with us some of the ways they anticipated sustaining their different grant activities once the grant funding ended. The most common method was they had internal commitments to continue sustaining those successful elements of their grant program. Another component was seeking external funding through community grants, other federal grants, and opportunities of the like. So I just wanted to give you guys a taste. There is a full report forthcoming, and we look forward to sharing that with you very soon. But with that, I don't want to take any more time from the stars, so I'm going to turn it over to Phyllis.
Thank you, Heather. It is indeed a pleasure and a privilege to be with you all today and to share with you all that Illinois is accomplishing and has accomplished in terms of providing services and interventions for people living with dementia and their caregivers or care partners. The State Unit on Aging, the Illinois Department on Aging, has been awarded actually 3 ACL discretionary grants for Alzheimer's interventions and services. So for the purpose of today's webinar, and for the sake of time, I'm going to be speaking on these grants collectively, but should you have any questions on the individual grants, please do not hesitate to reach out and ask those questions. So prior to applying for our grant in 2014, the first grant, we had to set some goals. We had to ask ourselves, what do we want to accomplish as a result of receiving this grant? Well, first thing we wanted to do was to assess the dementia capability of our aging network. And that's just a really fancy way of saying, what services and interventions do we have in place and where are the gaps in services? And after we did our assessment, then we also wanted to form some new partnerships with our community providers, and we wanted to be able to pilot and in some cases create programs. And once we had piloted these programs and deemed them successful, we wanted to be able to expand those services with other partners and also sustain those services as well. So we chose to use ACL's Dementia Capability Assessment Tool, and this can actually be found on the ACL website. So we surveyed some community-based organizations. We surveyed our 13 area agency on aging and also other state entities as well. And as a result of that dementia capability assessment, we found that, as expected, there was a need to address the special needs of people living with dementia, but we also found there was a huge gap in education and services for the care partners of those individuals as well. So I want to shift and talk about the partnerships that we formed during the grant. We first established our relationship with SIU School of Medicine's Alzheimer's Center during that first grant. And because of the wonderful work that this entity had been doing in downstate Illinois, we asked them to partner with us in piloting Savvy Caregiver in central and downstate Illinois. And it's interesting to note that the next 2 relationships, a relationship with the Alzheimer's Association and with the Coalition for Limited English-Speaking Elderly, or CLEAS, came out of that relationship with SIU. And SIU's head of their Education and Outreach Department had this great working relationship with the CEO of as it was called then, the Illinois chapter of the Alzheimer's Association, and he suggested that we bring them in. And so when we brought in the Alzheimer's Association, they also suggested a partner, police, in order to address limited English-speaking elderly in the Chicago area. And of course, we could not do anything. We could not accomplish anything without our 13 area agencies on aging. 9 of our AAAs actually participated in one or more of the grants, and currently all 13 of them have programs in place as a result of those grants. Now, this next slide is an inclusive list of services and interventions that we established and possibly created with ACL funds, but I'm not going to take time to read all of these and go through these right now with you. I'd rather look at them as we cover the role of our individual partners. Let's start with SIU School of Medicine Center for Alzheimer's Disease Research and Treatment. As we mentioned before, we introduced Savvy Caregiver during our first ACL grant, mainly in Central Illinois. And we were able to bring in Dr. Kenneth Hepburn and his team. At the time, they were with the University of Minnesota, and they trained not only facilitators of the program, but they also trained master trainers. So we started with SIU staff and AAA staff and their providers. Then during the next 2 grants, we were able to expand not only to different providers and different organizations, but we expanded the program to unserved parts of our state. And I want to take a look briefly at the next 4 interventions and just mention them: Stepping Up, Time Slips, Music and Memory, and Opening Minds Through Art. I want to note that these were established, they were piloted and established through SIU's Alzheimer's Center with grant funds, and they are currently being sustained at SIU. Stepping Up is a fall prevention program designed specifically for people living with dementia and their care partners, and it's based on the HADI exercise program. Time Slips and Music and Memory, the grants funded the training and the establishment of the program, and then SIU School of Medicine trained trainers in our adult daycare centers and some senior centers, and they also offer these programs in their memory clinics as well. And Music and Memory actually grew another partnership. SIU partnered with the King's Daughters Association here in Springfield. King's Daughters Association agreed to purchase MP3 players and iPods, in other words, the devices for the program, while SIU was responsible for sustaining the program itself and training facilitators. Opening Minds Through Art, or OMA, was a program piloted through SIU, and 2 more relationships came out of that, with the Springfield Art Association and the Hoogland Center for the Arts. SIU trained Art Association volunteers and one-on-one volunteers to partner with the participants, and at the end of each 6 to 12-week session, they hold an art show at opening night at theater productions at the Hoogland. So if a person purchases a ticket to a play or a musical, they have the added bonus of possibly seeing an art show and being able to converse with the artist as well. As we mentioned before, the Alzheimer's Association was an essential part of rolling out Savvy Caregivers statewide. They conducted not only sessions for caregivers, but also trained some of our AAA staff and their providers, as well as the police trainers. Care Navigation is a program that was developed by the Alzheimer's Association, which uses master's level caseworkers and assess people by phone or by Zoom, sometimes in person, depending on the preference of the individual and their caregiver. And they navigate through the services that are available in their area and make referrals and develop that care plan. As I previously said, the partnership with CLEAS came through the Alzheimer's Association. Basically, the Alzheimer's Association trained bilingual CLEAS staff in English with the hopes that this curriculum would someday be available in more languages than currently available. Although CLEAS staff currently offers the English version of Savvy Caregiver, they can provide assistance to the limited English-speaking participants and help them better understand the curriculum. And during the course of our grant, they focused mainly on the Asian community in the Chicago area. And our 13 area agencies have worked diligently to provide these programs within our aging network. And many of the 13 area agencies had offered Savvy Caregiver. Most of those facilitators were trained by master trainers from SIU and the Alzheimer's Association. Another evidence-based program, Stress Busting for Caregivers, was piloted in the Chicago area by one of our area agencies on aging, Age Guide in Lombard. And this program was proven to be very effective in reducing stress for the caregiver. And we found during the course of both the grants and after the grants ended that stress busting for caregivers is a wonderful partner to Savvy Caregiver. While Savvy Caregiver focuses mainly on the caregiver education with one short unit on the self-care of the caregiver, stress busting, on the other hand, takes the opposite approach. Stress busting focuses primarily on the self-care of the caregiver with a short unit on dementia itself. So you can see how those partner well together. Supportive gap filling is pretty self-explanatory. Our goal is to keep people living with dementia in their homes and communities for as long as possible, and there's so much that other sources don't cover to achieve that goal. Sources such as Title III, Medicare or Medicaid or private insurance, there's so much more that they need. So gap filling funds actually fill in the gap. We have paid for interventions, equipment, GPS, home wandering alarms, home modifications, and so much more, and it has fulfilled a great need with our participants. Dementia Friendly America Initiative was also introduced by our area agency up north, Age Guide, and we also piloted it in another very distinct part of our state, in the southern part of our state, Age Smart Community Resources in O'Fallon. And if you're not familiar with Illinois, that's kind of in the metro East St. Louis area. We also piloted in both of those areas our dementia care specialist training. And this training was geared to anyone in our aging network who works with people living with dementia and their caregivers in a non-clinical setting. So this could have been a wide variety of participants. We could have case managers, AAA staff, home-delivered meal volunteers, APS personnel, and so much more. But they had to work with our clients in a non-clinical basis. Now, we're really proud of what we've been able to accomplish in Illinois, but nevertheless, there have been challenges. So I wanted to share with you some of the challenges that we faced and how we met those challenges head on and how we dealt with them. The first program that we found a challenge was Stepping Up. And as a refresher, this is the falls prevention program that was developed by SIU. We found out fairly quickly that our trainer requirements were just far too stringent. In the beginning, we required facilitators to be either a licensed occupational therapist or a licensed physical therapist. And we found out that was really difficult to expand that program. The program mainly stayed with SIU because they had those personnel to provide the training. So, keeping the safety of the participant in the forefront, we tweaked those requirements and listed those particular requirements that you had to be a licensed therapist. We added different certifications that were a little easier to obtain but still maintained the safety of the program, and ones that SIU were able to provide free of charge. As an example, we required that the facilitators have CPR certification, and SIU was able to offer that certification for the potential facilitators. Moving on to care navigation, this was the program that was created by the Alzheimer's Association. And the challenges that we found with this is we found out our paperwork was way too much. We wanted to make sure that this intervention was well received and that it worked, but the pre and post paperwork was too much. So we had to scale that back. And then we also found, because this is a 24-hour, 7 days a week service, master's level caseworkers were really hard to entice. As you can imagine, a lot of them don't want to work those evening hours and the overnight hours. So that was hard to expand that program. So actually, this program has been discontinued at the Alzheimer's Association. But the good news is we took the basis of that program and they took what they learned and formed a different program, created a different program called the Online Navigator. And this program is a support and care plan development that initially is worked with the caregiver and the person living with dementia. And then once they have gone through that particular part of the program, then they meet with the master's level caseworker. And so that has worked out much better for the Alzheimer's Association. Dementia care specialist training. After the grant ended, we were in our fourth session of this. It was very well received and was very well attended. And then March 2020 hit, and our state was shut down for COVID-19. Because this is a combined in-person and online intervention, we feel that the in-person sessions are very, very important, and we have not continued those again since the pandemic. The online version is still available upon request, but we are really hoping that at some point we can reinstate that online, or I'm sorry, the in-person version as well, the in-person sessions. So we did all these great things with this grant. How do we keep them going once the grant period has ended? How do we sustain it? Well, in Illinois, we petitioned our state legislature, and I am happy to say, have been awarded $1 million in annual funding for the last 3 years, fiscal year 20, 21, and 22, in order to sustain these programs. And we expect this funding to continue. I do want to point out, though, and that we have a very strong ally in our Lieutenant Governor, Juliana Stratton. She was a caregiver for her own mother who lived with dementia for a number of years. And so we have a strong ally in her. So you're probably asking, how did we get the state legislature to award us this money? Well, one word: data. We were able to provide outcome data that showed positive impacts on the person living with dementia and on their caregivers. And they also showed that the interventions were well received and they were recommended by the participants to other participants. Now, that sounds really daunting to get that kind of data, but I do have some advice on the way that we handle that. Keep in mind that ACL requires an extensive amount of data as a result of the grant. So my advice to you is make sure you know the grant requirements and you are very familiar with the approved collection instruments, and be a resource for your partners in these grants. Keep in close contact and make sure that data is actually being collected. And if you are implementing evidence-based interventions, more than likely they have a data collection system in place too, so you can use what you glean from that data as well. Also, don't recreate the wheel. There are so many instruments out there that have been tested and used that produced wonderful results for us. For example, one that we used extensively that produced results that showed our interventions were working very well was the desire to institutionalize scale. This is a 6-question scale that we use both pre-intervention and post-intervention. So I would suggest that one. There's numerous other ones: the Zaret Burden Interview, the Healthy Days Core Module, the Promise Global Health Scale, and Revised Memory and Behavior Checklist. Just look for some other instruments, and I guarantee you will find some that you can use. Also, be sure to use your state data. We got a tremendous amount of data on Illinois from the Alzheimer's Association, and we also used our census data as well as data from the Kaiser Foundation. And I can't suggest strongly enough that find a partner to help you. We were so very, very fortunate that we partnered with SIU's Research and Development Department, and they were able to collect the data and analyze the data on the first 2 grants. On the 3rd grant, we have to give the credit to our Planning and Research Department at the Illinois Department on Aging. They were able to help us analyze and collect that data as well. So we weren't on our own at any point on this. So how did we know which interventions that we wanted to sustain? Well, I pointed out on this other slide that many of our partners sustained the interventions. So we looked at the ones that weren't being sustained or only sustained in part by our partners. And we looked at the ones that had the most reliable data and the ones that were the most well received. And we came up with Savvy Caregiver, Stress Busting for Caregivers, and Supportive Gap Filling. I do want to say that many of our AAAs, as well as SIU, have currently stopped funding Savvy Caregiver for fiscal year 2022. And that is not a bad thing. That's actually a fabulous thing, because we've done such a good job of training so many organizations and providers on Savvy Caregiver that they can receive that training elsewhere, that the AAAs don't have to fund it exactly, but they can refer them to different entities to get the same training. We did get permission to conduct both Savvy Caregiver and Stress Busting for Caregivers virtually during the pandemic. Because of the success of these programs and how we've been able to enlist the help of our 13 area agencies on rolling them out, because of the tremendous success, we've added a clause for fiscal year 22, and this gives our AAAs the choice of offering a different evidence-based program as long as they have prior approval from IDOA. But truthfully, it has been gap filling, supportive gap filling, that has fulfilled the need during the pandemic. When the state shut down, the needs became immediate, specific, and urgent. So many of our AAA shifted some or all of their funding to gap filling. Another intervention is the Dementia Friendly Illinois initiative. It's been very successful. When we looked for a way to fund it, we didn't include it into the state ADRD funding, but we took a look at a small grant that we had in place for a number of years, the Illinois Long-Term Care Systems Development Grant. And much of the money was going into monitoring of our community care care coordination units and other entities. But when we really took a look at it, we found that we had internal staff at Illinois Department on Aging that could actually do that monitoring for the AAAs. So we rewrote the grant deliverables, shifted the monitoring to in-house, and we were able to use this funding to establish dementia-friendly communities in our 13 AAAs. It's the expectation that each AAA establishes one additional dementia-friendly community by the end of our by the end of the area plan cycle in 2024. But our AAAs have stepped up and gone above and beyond it. Some of them have committed to establishing 2 communities, and some even 1 per year or 3 communities. So I want to thank you so much for this opportunity to talk about the great things that are happening in Illinois. And I do want to say that we are so very grateful for the ACL grants that gave us a place to start. And we'd like to pay that forward. So if you had any questions at all or any questions about the programs or questions about the grants itself, please do not hesitate to contact me. And now I will turn it over to my colleague from the great state of Hawaii, Christy Nishida.
Thanks, Phyllis. Aloha, everyone. I'm very happy to be able to share our work implementing and sustaining dementia programs in Hawaii. Our ACL work is funded in Hawaii, and here you can see a beautiful aerial photo of our University of Hawaii campus where I work. And I'm also showing you a picture of our island state because it's relevant to understanding our challenges as we deliver and sustain services across the different islands statewide. Our initiative is called the Hawaii Alzheimer's Disease Initiative, or HADI for short, and I serve as the principal investigator. I also want to recognize my team for their valuable contributions as well, Dr. Rita Bell Fernandez and Jody Michon. I would like to show you our collaborators. These logos feature nonprofit and government agencies that partnered with us on this grant. And I'm recognizing them because it again relates to sustainability. Our leadership team is part of the university, so we don't provide direct service. We depend on our partners. So these agencies and organizations partner with us because they're passionate about doing better for their clients with dementia. So our role at the university has been in being good partners to provide resources and support for implementation, evaluation, and sustainability. The goal of our initiative is systems change to support dementia capabilities statewide. We strive to support persons with dementia and their caregivers in person-centered, coordinated care in the community. Today, when talking about building this dementia-capable system, I will focus on 3 aspects of our initiative: our interdisciplinary memory clinic, the Memory Care Navigator program, and the Savvy Caregiver program. So first, I want to talk about our interdisciplinary memory clinic. The first clinic was created at a federally qualified health center on the island of Oahu in 2010 by a member of our team, Dr. Fernandez. And through our HADI grant, we expanded to 3 other FQHCs and a senior center. Here's our rationale for expanding and creating these memory clinics. First, patients often don't have enough time with their primary caregiver, primary care provider, certainly not enough time to evaluate for memory loss. In addition, there's often a long wait to see specialists, and that's particularly true on our neighbor islands. And as we know with dementia, given the length of the illness and the patient's complex needs, an interdisciplinary approach is often needed that includes overall brain health and fitness. So for us, this was our rationale for the clinic. And you can see the different components of our memory clinic here in the circle. So in this once a month half-day clinic, patients and caregivers rotate through these different stations. So they spend time with a geriatrician, behavioral health specialist, a dietitian for nutrition education, and a social worker. Turning to our challenges, a main challenge in implementation was the recruitment and retention of health providers at the FQHCs at the site of the memory clinic. One of the clinic sites was on the small island of Molokai, and there was a good amount of turnover. So as a result, there was an ongoing need to train staff and for ongoing technical assistance as well at all the memory clinic sites. So despite these challenges, here are a few critical things we learned for sustainability. First, getting buy-in from the FQHC leadership was important, and maintaining that buy-in helped withstand staffing changes. So in the beginning, we pitched the memory clinic model to all FQHC directors at an association meeting. And those who saw the value for the patients that they served were willing to partner with us. The model, the memory clinic model, needed to make sense to them, and they needed to see the efficiency in serving a good volume of dementia patients in half a day. The different healthcare professionals who participate in the clinic bill the insurance companies for visits as usual. The FQHCs also track patient characteristics, services provided in their universal data system as usual. And finally, for sustainability and for replication, we are working on a memory clinic toolkit right now that will outline all the factors that supported the development and implementation of the memory clinic. So this toolkit will help in replication and sustainability as well. Next, I'll turn to our memory care navigation program. The navigation model was developed with consultants from ACTA and Alzheimer's, and then we trained public health nurses and social workers on this model so they would have an additional tool in their toolkit when helping clients with dementia. The focus of this navigator model is on educating, supporting the family, and connecting the family to community resources. To ensure quality and fidelity, we created and printed a memory care navigation roadmap for our caregivers. And you can see pages from this tool here. So this is the first page, and the full version on our website. So the roadmap contains the navigation algorithm, which you can see here, which walks the navigator through the process of screening and referrals for services. It also includes the mini-cog tool and also a triage system for navigators to know how to address different client situations, as well as a listing of community resources. So this roadmap was very useful to us because it helped to ensure both quality and fidelity to the navigator model. The navigators can take the printed copies with them in the field and refer to them. And at the same time, the Memory Care Navigator Roadmap tool helps us to ensure sustainability of the model, as well as new public health nurses or social workers are trained and onboarded. So our biggest challenge was maintaining the commitment of the organizations to partner with us and have their social workers and nurses implement this model over time, and particularly in continuing to track data for us. The navigator role was not a separate paid role. The social workers and nurses had to voluntarily commit to implementing the navigator model when working with clients with memory loss or dementia. So to date, a subset of the organizations we trained have stayed with us and committed to the model. To support sustainability, we worked closely with the organizations that we trained. We presented this model to the organization's leadership as an additional tool, again, in the social worker or nurse's toolkit, and we were clear that we were not just providing free training on this navigator model. Our intent was to partner with them, to partner with the organizations, be able to track the implementation of the navigator model with their clients. Buy-in from leadership, again, was key, and we did find champion staff within each organization who saw the value and were committed. In addition, we have videos of the original memory care navigator training housed on our website and has been very useful as a refresher or to train new staff as well. Finally, I'll talk about the evidence-based HADI Caregiver program, a 12-hour psychoeducational program for dementia caregivers. This is a photo from our initial training of HADI Caregiver facilitators who were largely healthcare professionals from the different islands. Our biggest challenge was in the retention of trained facilitators. Facilitators were volunteers and encouraged to integrate this program within their organization. Nevertheless, we did have an uneven commitment, and today 2 out of the 18 we originally trained are still with us today. So our statewide reach has been limited, and in addition, we faced issues in terms of balancing fidelity to the SAVI model with the need for adaptation to be more culturally tailored to our diverse communities. So we worked closely with Dr. Hepburn and Emery to determine that right balance. Despite these challenges, our 2 SAVI trainers have been very committed, and they are helping to train new facilitators and will mentor them as they lead their first classes. And also, as already mentioned, we culturally tailored the HADI Caregiver model to the diverse communities that we have here in Hawaii. We used an iterative process that included feedback from dementia caregivers to refine the HADI Caregiver curriculum while maintaining fidelity to the core content, the core principles within the model. So the culturally tailored version, which includes localized content, local examples, and a session 0 in order to build rapport and trust amongst the caregivers, was more accepted by the caregivers themselves as well as the organization. So this cultural tailoring helped with sustainability as well. So I highlighted 3 of our major activities, and here is a summary of our lessons learned. Again, buy-in from organizational leaders. We needed this commitment to sustain the program despite challenges like staff turnover. And these organizations that we partnered with needed to believe, in the benefits and wanted to better serve those with dementia. We developed tools for fidelity and sustainability. An example of that is a memory care navigator roadmap that our navigators took into the field. And we needed to look for ways to embed the programs within the organization in the ways that made the most sense, within their current workflows and without additional burden to the staff. And finally, culturally tailoring to the diverse communities here in Hawaii to improve acceptance and sustainability of the evidence-based program. A few additional efforts in Hawaii. Recently, our state legislature funded a state ADRD coordinator position, and this will help us to support implementation of dementia initiatives and policies. Our Hawaii State Plan on Aging and our state ADRD plan includes commitment to dementia programs and initiatives. And finally, we strive to integrate dementia capability within larger systems as well, including the No Wrong Door network that we have in Hawaii. And so we continue to work on our network, on our systems of care here in Hawaii, and look for ways to strengthen HADI programs and services and improve referrals and coordination, as well as resources for sustainability. It's an ongoing process, and we continue to be focused on our goal of a person-centered, dementia-capable state. If you have any questions or comments, you can also send them to my email on the screen. Thank you so much for your time today.
Thank you, Christy and Phyllis and Heather. What wonderful presentations, lots of fantastic information shared. We're going to move to the question and answer part of our program now. You can enter your questions into the question and answer chat pod on your screen. And we already have some questions that have come in, so I will move forward with some of those. One of the questions we wanted to get to is one sustainability approach that might be used could be applying a reimbursement method. Could all of you kind of chime in on where, for Phyllis and Christy, where your state stands, a little bit more detail on any reimbursement methods you use, and then Heather, if you can give kind of an overview of what you found for the review of the various grant programs. Maybe start with Heather, since she can give like a summary, and then we can follow up with some specifics.
Sure, thanks, Sari. So there were, a handful of states or grantees, a handful of grantees that did acknowledge that part of their sustainability plan was finding ways to bill for their services, whether this was the provision of support for caregivers, whether this was charging for the training that they were now expert in. Some of these reimbursement things could be using billing codes for Medicare. In addition, some places were also shifting to private pay, asking for clients and participants to pay out of pocket to reimburse for the services that they were receiving. So that's just a handful of some of the examples that we saw in the final reports.
Great, thank you. Christy, do you want to chime in?
Sure. So for our interdisciplinary memory clinic, it was critical that we think about how to sustain and look at reimbursement. So I think key for the interdisciplinary memory clinic is that the different providers billed as usual. So the physician billed as an office visit, the site behavioral health specialist, the social worker as usual for their office visit. And so I think this was really critical in terms of getting buy-in from the FQHCs and to sustain it, is that they would see that they would bill as usual, but that there was efficiency in terms of being able to serve a bunch of patients in a short amount of time during that clinic day. So I think yeah, reimbursement was definitely key.
Great, thank you. Phyllis, any experience in Illinois that you can point to?
No, our state unit on aging and the office that I am in is the Office of Older American Services. And so those services all are under our area plan, including the state funding. So we don't charge, those are all offered free of charge to the participant. We fund the provider. And then so we don't have any experience with pay for service as far as our Alzheimer's programs and dementia programs go.
Yeah, so just kind of pointing out that different states and entities will have to arrange the reimbursement models differently based on the agency we're talking to here and the agencies that exist statewide. So thank you for those responses. A specific question about the group visit model came in, Christy. Someone was asking, was that just overwhelming to any of the providers to handle so much at once? Was the caregiver or overwhelming for the caregiver and the person living with dementia? So can you talk a little bit about how you were able to make that a workable model for both the caregiver, person living with dementia, and the providers involved?
Sure. Well, first of all, we limited the capacity per month. so that we had a good volume, but it didn't overwhelm the providers. So we learned based on experience, how many was an ideal number in that half-day memory clinic. So for us, it was 8 to 10, and there were, no-shows sometimes, but we knew that we needed to recruit about almost twice as much, and then we would and then the clinic day, we would have about 8 to 10. So we knew from experience how much we could handle, or the providers could handle. In terms of it not being an overwhelming experience, we definitely did not want it to be too hectic. So we had a table, a welcoming table that we called our Aloha table, where folks came in and sat down, and we had a university student come and talk with them and just make it very casual and welcoming. And this table was also where group education was delivered, for example, by the nutritionist about healthy brain foods. And so from there, when the different stations were open and available, then the university student would help to walk the person and their care partner to the different stations. And so it wasn't too overwhelming or chaotic, in terms of the process. We tried to keep it very, very light and easy that day. And having someone like the university student just talk with the family and be able to escort them to the different stations was very useful.
Right, it's kind of like having a guide for the day. You didn't have to wander the memory clinic on their own trying to find the next location. So the next question is for you, Phyllis. We have a question come in about Savvy Caregiver in particular. If you have any data related to caregivers who may have refused Savvy Caregiver and possibly the reasons why they may have done that.
We do not collect data on anyone that would have refused Savvy Caregiver. Sorry.
Okay. Did you hear anecdotally reasons why people may have not used services that you were providing, or also just not something that was collected?
What I have heard stories from our area agency on aging is that in the case of spouses, many times they don't like the term caregiver. They say, so if you approach it from that angle, that you're the caregiver for this person with dementia, many of them will say, I'm not a caregiver, I'm his wife, or I'm her husband. And so that kind of turns them off. But that's really the only anecdotal thing that I have to share as far as Savvy Caregiver goes.
That's helpful. Thank you.
Mm-hmm.
Christy, do you have any comments about refusal of services, or why you may have had any uptake issues with any of your programming?
No, I guess our approach was to market and advertise, the training. And so those that responded, were interested in the Savvy Caregiver program. And so some of the ones that we turned away were those who weren't taking care of their loved one at home. The person was in a facility of some kind. So that's mainly the reason why we didn't include them. But once we had the caregivers, and again, they signed up because they were interested, and we've had a very high retention rate too, in terms of sticking with the 6 weeks of the program as well.
Great, thank you. Erin chimed in with me, and I have heard this as well, that sometimes some of the interventions just seem like they're too much of a time commitment for caregivers. They feel stressed with everything they have to do and just feel like they can't fit another thing in and can't imagine that their stress would possibly be lowered. So sometimes it's a sell feature to try and let people know that these programs really can have some good benefit. Heather, do you have any comments on items that you found with the closed grant report?
So I think one of the things, just to reiterate what was just being noted, some of the grantees did note that there was sometimes a challenge of those evidence-based programs or the behaviors and management, other services being a little too time-intensive for caregivers' ability to attend on a regular basis. Something else that was recently mentioned had me thinking about some grantees, I don't know if struggled is the right word, but needed to take additional efforts to reach out to maybe hard to reach populations, whether it was reaching out to some racial or ethnic minority groups that they hadn't worked with previously. Maybe there was some limited English language individuals that they wanted to reach out, but they needed to, make some adjustments, get the right staff involved to be able to reach this whole range of individuals that can benefit from these programs. So I don't know as much exactly about lack of uptake. I think that was the initial question. But as we're well aware in this field, there can be a host of reasons that contribute to the unique circumstances of each of these caregivers. So.
Great, thank you. I just want to touch on one more question that has come in, and Christy, I hope that you'll be able to shed some light on this. In terms of adapting programs to be culturally appropriate, were there any cultural adaptations you needed to make in order to best suit the Asian Pacific Islander population which is obviously the majority of the population you worked with in Hawaii, but are there any adaptations you needed to make in order to ensure the programs were culturally appropriate?
Yeah, sure, definitely. So yes, we're a very diverse state, and we weren't necessarily tailoring to one particular AAPI group when we tailored Savvy, but it just needed to feel more local, if that makes sense, in terms of examples that were given and just the approach. So we decided to add this session 0, which I referenced. And what that means is before we started the 6 weeks, we had an initial session for the caregivers just to get to know each other. And it was an interesting comment that one of our facilitators said, that they're the younger person in the group and the people surrounding her, the caregivers, are her elders. And so it was uncomfortable to just start providing advice, and doing the Savvy Caregiver curriculum. There needed to be a point where, building that rapport and that trust for her to be seen as someone, that the caregivers could trust and work with. And so we wanted to make sure that the core concepts were the same, but oftentimes it's the way it's delivered in terms of being culturally tailored. So that's our experience in Hawaii.
Great, thank you so much. Well, that about is the amount of time we have for today to go through questions in our presentation. I want to thank our presenters again for their excellent presentations and thank all the participants for joining us. I will turn the floor back over to ASA for some final comments.
Thank you, Sari. Heather, Christy, and Phyllis, on behalf of the American Society on Aging, thank you so much for a very informative webinar today. If you would like to claim CEUs for today's webinar, you will be receiving a follow-up email by the end of the business day that will contain a link to the CEU application. That follow-up email will also contain a link to today's slides. Please note that you have 60 days to claim your CEUs for today's webinar. And also, please note, it will take 30 days from the date of your submission in order for ASA to process and issue your CEUs. Thanks again for joining us today, everyone. Have a great day.